And away we go. So, welcome everybody to another bonus interview, actually, with our guest, Dr. Joey Allbritton, who's actually been on before. But tonight, we are actually taking a deeper dive into the hybrid business model of cash pay versus cash pay and some insurance options. We had the pleasure of interviewing a cash pay expert last month, and now this month we're going to look at the option of sprinkling in some insurances as well, because it's not all doom and gloom out there, as social media will have you think. So, Joey, thanks for coming on, man. We
Yeah.
appreciate you.
Thanks for having me, man. Yeah, I think it's nice to kind of look at some of it because we've got guys, about a third of our clients are 100% cash based. So I'd say probably the other third are hybrid, and then the other third are like deeply in network. So
Yeah,
all of them can be profitable. The way we kind of look at everything is what do you actually want out of the business? Like, where's the destination? And then from there, that's way more important than the actual vehicle to get there. And so once we know that, that'll kind of dictate whether you go all cash, whether you go hybrid, taking one or two insurances, or whether you just go full fledged. Because like up in the Northwest, like their average reimbursement's $160 a visit.
right,
And so like it almost never makes sense to just go all cash based there.
right.
And so there's just some of those things to kind of inherently know. And so just so I know, is this because I know University of St. Augustine has like different ones. Is this just Texas? Is this Texas
No,
Florida?
this
Is
is open to all
this okay?
students on all campuses. So
Okay.
anybody interested in business and entrepreneurship, primarily physical therapists on the Austin campus. But
Okay.
yeah, it's open to everybody, all campuses, all chapters, all sections too. So PT, OT, speech, PA,
Okay.
nursing, all that.
Cool.
But moral of the story is let's just look at rehab in general or physical therapy and, private practice. And the almighty question, should I take insurance? So
Yeah.
let's start there, because I think one of the big things is it depends, which is
Yeah.
ironic, right? But it's a state by state thing too. So
Yeah.
go ahead and tell us a little bit about that. Should I take insurance?
Yeah, so kind of like I alluded to at the start, a lot depends on really what your goals are. So I've got some guys who just want to be solo and they want to kind of have a lifestyle business. They treat 15, 20 visits a week. Does that make sense to take insurance? Probably not. If we're trying to grow to 5, 10, 15, 20 clinics, will you probably need to take some insurance? Yes. Is our goal to rapidly get out of treatment as fast as possible? Which I know for some of you all that are like students right now, you're like, I love treating, I'm just now starting. But like, there's a lot of people that once they're a couple years in, they're like, yeah, I'm kind of good. And so once you kind of figure out what you want, if you take insurances, you can grow significantly faster and get out of treatment. But a lot of times that's going to be at the detriment of what you're making per visit. And so whether you take it or not is very variable on what your overall goals are and what state you are. So like I know you've got Florida and Texas from University of St. Augustine. If you're in Florida, you're less likely to take as many insurances if you're trying to maintain like an actual lower volume kind of clinic because the actual reimbursement in Florida is significantly lower than let's say in Texas. So like Texas right now, your average reimbursement for Blue Cross Blue Shield is like 135, 140, depending on what you're billing, if you're billing properly. A lot of people miss bill and they do their like AMA bill. They don't know a difference between AMA and Medicare billing. And so they're doing 8-minute roll billing and they're only doing 4 units in an hour when you really could be doing five with Blue Cross Blue Shield. I know that's kind of a small nuance, but like most people don't realize that. So then I've had literally someone in Austin decide to drop Blue Cross Blue Shield because they're like, it's not worth 90, $95 a visit. I'm like, well, that's because you're billing wrong. And so once they realize that you could do that, they realize it can start to be profitable. So um, just so y'all kind of inherently know, can you allow me to share my screen? I can
Yeah,
walk you
man.
through some numbers that I think will give y'all some better insight. And I think this in itself will probably dictate whether you'd want to take insurance from a treatment philosophy standpoint. And just so I kind of have an idea here, out of y'all that are here, how many of y'all are like pretty sure you're going to be opening a clinic, at least in some capacity? We're just trying to figure out what kind of model we're at. Okay, so I see a couple hands raising. We've got some there. Some are just, I think, here for the ride. And so we'll kind of see what that looks like. And so really what it all comes down to, can y'all see my little whiteboard that I'm drawing on here?
Hmm.
All it really
Yes.
comes down to is just knowing what your available visits is compared to what you're actually making per visit. And so all that means is if we want to maintain 60-minute one-on-one, we know that that effectively means that our average reimbursement per visit just needs to be above 140. And so if we know that, that means we can see just 8 people a day. Well, if we aren't at 140, which like if we were completely in network in Texas or Florida, you likely are not above 140. Like you need to have some type of cash or out of network to be above 140. But if we're like, okay, well, like I actually don't really necessarily think everybody needs 60-minute one-on-one. Instead, what you can do, there's kind of the option of like 30-minute scheduling, 40-minute scheduling, and then 45-minute scheduling. And so these are kind of the options. These are all kind of implied, hey, we're doing 60-minute sessions, but essentially like every 30 minutes someone comes in or every 40 minutes someone comes in. But if you have federal payers like your Medicare or TRICARE or Medicaid, you are not doing overlapping of them because they do not allow that unless we're getting into like group codes and stuff like that. And so really all that means, guys, is if we are less than 95 average reimbursement per visit, we've got to be doing 30-minute scheduling and seeing at least 16 people a day. And if you're getting even way lower than that, where we're getting into like the 70, 75, that's when you start getting into like the really, really high volume stuff where like you probably just need to be dropping insurances that aren't paying you the way you need to do it. And so what most people fall into is they're like, well, I can't afford to do 60-minute one-on-one. I don't want to do 30 minutes because that's a lot of volume. So they usually pick halfway between, which is right here at 45-minute scheduling. But I'll show you 40-minute scheduling first because realistically, that means you can see 12 people a day. That's a very reasonable caseload for most people. And so as you kind of get used to it, like this is tough. Like if you get to 16 visits a day, you probably need a tech, you probably need an aide to help you with stuff. So I don't inherently love this model if we don't have to. But in Florida, New Jersey, New York, some of those places where your average reimbursement is lower, you do get into some of these reimbursements. And so you do kind of have to get into here if you're not willing to get better at sales and get better at marketing and do more out of network. And so this is kind of the next logical one. We like this scheduling if we can't fit the actual like above 140, because the inherent issue you run into if you do 45-minute scheduling is in an 8-hour day, you can only see 10.667 people. And as you imagine, you can't see two-thirds of a person. And so instead of rounding up and then having to pay everybody overtime, most people round down. And so what that means though, is if there's 2 available slots right here per provider available, that means even at $100 average reimbursement, every single week, there's 10 slots that provider could have been seeing just by doing 40-minute scheduling. Times that by 100 for just average reimbursement of 100, times that by 4.2, you're effectively leaving $4,200 a month on the table by doing 45-minute scheduling. So we don't really love 45-minute scheduling. You can make it work a little bit better if you do 4 9s and then a half day on Friday. But 40 is cleaner. And from a billing Medicare 8-minute rule, all those extra 5 minutes were worthless anyway for that because you're not really billing another unit until you get to 53. And so 40 is usually what most of our hybrid guys do because as long as you're between 95 and 140 average reimbursement, you can only see 12 people and be very, very, very profitable. And the way we got these numbers, guys, is we try to get it to where based on whatever this like lower tier of your average reimbursement is, times your available slots. So it's like if you do 60-minute one-on-one, you should have 40 available visits. That should come out to be $5,600. And the reason we do that is we know the national no-show cancellation rate is 14%. And so instead of having to have unicorn scenarios of like us all like having like 100% show rate, everybody's not wanting to be completely full across the board, people get sick, like all of those kind of things or deductibles just reset, we just kind of bake it into our numbers. So that way, even if we're only 86% full, we can actually still have 20% profit, a 10% opportunity reserve, and a 5% tax reserve. And that's only assuming 86% full. And in the scenario of 60-minute one-on-one, we just have to have an average reimbursement of 140. Anything higher than that, it's more profit. Anything higher than the 86% is more profit. And this makes it to where our break even before we're losing money in the clinic is closer to 55%. So you can weather some bad storms of like, hey, one of our referral sources just stopped overnight. Hey, Facebook just changed their algorithm, something's going on. Whatever you need to endure, this allows you to not have to have a unicorn front office person who's amazing at sales, or for your marketing to always just be crushing all the time. And so this is why we set people up this way, because if you're all cash, you have to fix a lot of inherent things. Like you kind of just have to pick what your actual thing you want to solve for in your business. A lot of our guys that are all cash based, they don't love the billing side of things. They think the only way you can do insurance is because you have to have high volume, and that's why they inherently don't do it, because most of the places they saw insurance was at some of the sketchy chains that were making you see 4 people an hour. And in reality, you kind of just saw like the most you should see, even in some of your bad reimbursing, is usually about 16, maybe 18 in some of your areas, because maybe sometimes you double book on like the ones that like going into the end of the day or going into lunch. But you typically don't need anything more than that, because if you're getting down that low, just cut the insurance. Like you should not be dealing with some of these like $50 capitated rates where like the most they'll pay you, regardless of how long you see them, is $50. And so you kind of pick and choose whatever makes sense. So like if you're in Texas, a lot of times that's like Medicare because it's like 110 to 115. Blue Cross, it's 135 to 140. TRICARE pays good. And then maybe you'll do motor vehicle and personal injury stuff. And then you just do cash based. But I think there's also some delineation to kind of inherently understand what cash based even means, because there's a lot of people that'll say cash based, but that actually means something different to a lot of them. So cash based for some people, that means you tell them, hey, it's $200 a visit. That's what you pay. And like, that's it. For some of them, it's $200 a visit. You give them what's called a super bill. It gives them essentially an itemized thing saying these are the units you do. And you say, take that to your insurance company. Hopefully they pay for it. If they don't, not really my problem. And so that's one option. Out of network is still cash based, really, but you're actually billing on behalf of the client, just like you would if you're in network. And so a lot of our guys, when they start their business, they're usually cash plus maybe one or two insurance, or sometimes they're just all cash. As you get bigger, if you're wanting to grow faster, most people inherently start to either bill out of network or they start to take a couple of insurances because maybe they hit a bottleneck of like, okay, we were able to get to 2 or 3 PTs and we couldn't grow more. And so there's a definitely nice complement of it, but you've got to learn how to market and sell regardless. But it's definitely a bigger emphasis on marketing and sales if you're cash based. And if you're insurance based, you've got to learn the nuances of compliance a lot more. You've got to learn the nuances of billing. You've got to learn the nuances of probably managing a bigger team. And so there's some of those things to think about. But the other kind of nice thing about the hybrid model is a lot of times the way we actually teach our cash-based guys is we'll tell you like, and I'll tell you like for any of you that are looking at pricing in the cash-based world, I've yet to find a city that cannot justify a minimum of $150 a visit. Minimum. There's no reason to ever go below that. And so, and that's like rural, that's poor, that's rich, that's urban, that's everywhere. And we're in a 220 clinics right now. So like I've seen a lot of these pricings. 150 is the minimum. Most of our cash-based guys charge 200 plus, even if you're in rural area where quote unquote people can't afford it. Because most of the time we realize that it doesn't really matter how affluent, socioeconomic status, none of that matters. I've had physicians say no to a $3,000 package, and I've had someone who works at Walmart as a cashier say yes. It's really about like how resourceful that person and how actually like proactive they are in their health and how big of a problem it is. That's a bigger indicator than anything around how much they make. And so once you've kind of start to realize that, we just start to look at that and say, like, okay, well, if I want to maintain 60-minute one-on-one, because I've got guys that are die hard, like I'm 60-minute one-on-one, I don't care what we have to do to make it work. So what that means is, let's say you take a Medicare, that's 115 a visit. Well, then we need to balance that out with our cash prices. So that's why most of them charge a $200 to $225 a visit. The hard thing about this is if we're still trying to maintain 60-minute one-on-one, Medicare grows significantly faster than your cash-based side will. So you'll start to have like a 60% mix of the 115 here, and then maybe only a 40% here. So you do have to kind of make sure that your average for revenue per visit when you look at cash plus your insurance is always above this 140. If we start to dip, yes, you're still going to be fine. We have a lot of profit baked into it, but we don't want to always continue to be like, oh yeah, we should still be good. We should still be good. But this is what you have to look at, because the average of these will help pull these down here at the 115. The 200 will pull up the 115 to where we're above 140. Most of our guys that are like cash plus Medicare, they average around like 155, 160. And some of that depends on how you do your package structure. A lot of the cash guys out there, they try to tell you like, hey, do a 6 visit, a 10 visit, and a 20 visit package. And then they kind of discount differently based on like how big it is. You discount heavily or as you go there. I don't love this model because a lot of times when we see how much they've discounted, like this one, you're like not making money on because you discounted so heavily. For us, we just raise our prices and we just dictate whatever the actual thing you need. So like if you need 12 visits, you need 20, you need 40, it doesn't matter. It's what do you need? It's 20% off if they prepay the whole thing. It's 10% off if they pay half up front. And if they can't do that, they break it down into payments or you use care credit for financing. And so it kind of makes it a lot cleaner and easier for you to do it. It's truly customized because like it gets weird when you're like, hey, you actually need 8 visits, but I only have a 6 visit package and a 10 visit package. You're like, do I oversell you? Do I undersell you? Like, what are we doing here? And so when we do the customized plan of care, it makes it to where it's also easier to switch back and forth between insurance and cash because you still talk to them about like, hey, like to get back to where you're not having issues or worrying about falling with balance and fall, you're going to need to come in for X amount of visits 2 times a week for the next 8 weeks, whatever that happens to be. And so you're already doing the exact same sales process, whether you're cash or insurance. But the nice thing is once we start saying, hey, our cash rate's 200, when someone says, oh, $60 is an expensive copay, I can't even get my guys to pay $60. But when you price anchor and tell them, hey, like, luckily, you're going to need to come see us for like 10 visits. That would normally be $2,000 if we were if on our cash rates. But luckily, you've got really good insurance and you only have to pay $60 a visit. That allows you to have a price anchor to where your insurance, even if it's bad insurance, sounds significantly better. And they're more bought in on the value of actually using their insurance versus complaining about the fact that they have to do a $40 copay. And so there's a lot of those things, or like cash wise, or even a lot of your commercial insurances, they feel your like if you're looking at like 8 to 5 time frame, most of your like early morning, that's going to be like your cash pay or your commercials, like your Blue Cross Blue Shield. Your end of day, same thing. It's like Blue Cross Blue Shield or your cash guys. Well, who fills the midday? That's Medicare. And so it allows you to fill some of those times that are harder to fill and it gives you more stability. So it's like, I don't know about y'all, but like we're not in the best time as far as like economics right now. Like it's not looking amazing for America right now. And so I don't want to have a model that is dependent on people just having all kinds of excess cash flow to take care of their health when they're already paying their insurance. And so if we can kind of diversify the risk across these things by having cash plus maybe a couple insurances, you allow yourself to have less risk and you also can have referral sources because like I don't know if Jared talked about it, but like outside of concierge physicians, there's probably no doctors that refer to him, like almost across the board because he's 100% cash. And so the moment you take 1, 2, 3 insurances, that allows you to start getting all those referral sources. So we're not always dependent on Google ads or Facebook ads or going to gyms to do workshops or all of the other stuff. So that way, your actual cost per acquisition of a client is significantly cheaper. And so that's why we like it because, like, our big guys, like, we've got guys with like tons of clinics. Most of them don't need all of the like crazy, like, Facebook ads, Instagram ads, all of that type stuff because they just get referrals. And it's a self-sustaining business because as long as you have a good product, people will continue to refer to you. Where your cash base less, it can grow, but you're going to hit a limit of like how many people you can get in front of cash wise. And so like that's why like so Robbie and so just so y'all even know my background. So I've done nothing but marketing and sales for the last 7 years for PT clinics. My business partner, he went from 1 to 3 clinics and 1.7 million in revenue in 18 months with his clinics. He was more of what you'd consider insurance and or kind of hybrid model. And so it happens and it can happen very quick. I've yet to find any cash people go that rate. And I don't have any issues with someone that wants to be cash. I really don't care. It's what do you want out of your business? From there, let's delineate what is the best option for you. Because I've got someone right now that's doing right at almost 2 million a year, all cash pelvic. She just now in the last couple months started doing out of network billing. Before then, 100% cash. Here's a super bill. That's it. So if you want to do cash, I'll tell you pelvic is the money maker right now. Like pelvic is ridiculous. It's underserved. You charge 225, 250 across the board. The hard thing about pelvic though is it's all one-on-one. And so that's why you don't see a lot of them because most insurance models can't make it work. Because to maintain one-on-one across the board for 60 minutes, you've got to be above 140 average reimbursement. And so between it being a newer niche within the States, of course, it's way more normal in like Australia. That's like part of their healthcare for anytime anybody has a kid. But it's newer here, so there's not a lot of them, and it's hard to do and make it profitable in the insurance model. And so that's why anytime you see someone who's doing pelvic, they're almost always cash or maybe hybrid. And so there's different models that make more sense for different things, but I think that kind of gives you a good breakdown of kind of the pros and the cons and things to kind of consider. But like for me, Robbie and I are going to be opening and buying clinics in Texas starting 2017 again. And we are doing a hybrid model. Like we are not doing all cash, but we will be pretty much Medicare, TRICARE, Blue Cross Blue Shield, doing our motor vehicle, some personal injury, and then the rest will just be out of network billing. Like that's pretty much what we'd be looking at because we know that as long as we're above 95 average reimbursement, we can just do 40-minute scheduling. We're good. And it's a lot more profitable on the federal payers too, because you get 3 units. So like that's something to kind of walk y'all, like it's just a small little hack here. So like a lot of people don't ever do this math. They always try to see Medicare for 60-minute one-on-one in a 2 hour time frame. If we're doing 40-minute scheduling versus doing 60-minute, how many units can we get in 60 minutes? Four, not including untimed codes. We're not getting into any of that or strapping or anything like that. And then it's four for the next for a 2 hour time frame. If we do 40-minute scheduling, we get three, three, three. So you actually get 9 units if you were just doing nothing but Medicare, where you're only getting 8 when you do 60-minute one-on-one. And most of your Medicare populations beat by the time they're at 40 minutes anyways. And you'd probably get better therapeutic actual results by seeing them more frequently for less time. And you don't even get into the fact of like every time you build therapeutic exercise after the first one, they reduce how much they pay you. And so there's like some of those things that kind of factor in here. So between that and you have effectively 50% more available visits you can see by doing 40-minute scheduling versus 60. It's very easy to make money doing 40-minute scheduling because it works for commercials, cash, really literally everything. I say, and for me, I personally think 60-minute one-on-one is boring. Like I would be bored out of my mind staring at someone for 60 minutes for one-on-one across the board. I always kind of say it's like the analogy of like you go to a really fancy restaurant, the chef comes out and he just stares and watches you the whole time while you eat. Well, I'm like, I don't really know if I love that. Some people love it, some don't. And there's some disciplines that it makes more sense. Like one-on-one makes more sense for pediatric and pelvic and for your high like neuro, like some of your like maxicit, like you're not doing stacking of double patients or anything of any type with any of your neuro stuff. And so for those, like you really need to be like, okay, well, how are we going to make that work? And so you may have to do like hard 40s, or you may have to essentially always have a tech and just make sure your stuff is there because you're needing them for more like assist. But there's things to look at, but you just have to kind of figure out what you want out of it. But I know I've kind of rambled there for a sec there. But what questions do y'all have, or F. Scott, where do you kind of want to go from here?
I just have one more quick question before we open it up for everybody's questions. Like we said, it depends, right? You got to know the rates. I love what you did there because it basically shows the math. You
Hmm.
can't argue with numbers. The numbers are the numbers. It's just math, right? And you've already built in
Yeah,
the cancellation. Like these are real numbers too. It's
yeah,
not like,
yeah,
oh, we're hoping for the unicorn scenario. Like you said,
yeah,
this is real. People are going to cancel. Life's going to happen. So even if we include all that, we're still doing pretty well if we just follow these numbers, right?
yeah,
So again, we said it depends state by state because in New Jersey, reimbursement sucks. In
yeah,
Washington, Seattle, Washington area, it's pretty good.
yeah.
So the next thing is, all right, I'm going to decide to take insurance. What does that look like when you're going to try to negotiate that rate with insurance? Tell us a little bit about that.
Yeah, it kind of depends on who you're trying to do it with. Medicare, I mean, you're not negotiating
Right.
anything
No, you're
there.
just taking what they give you.
If I'm being honest, most of them you're not negotiating much with. Like there's not much there. And the easiest way that you can kind of see this, because technically we're not legally allowed to tell other clinic, like if you're in contract with someone, you cannot legally tell another actual owner what you are getting reimbursed. They call that collusion. It makes no sense because they do the exact same thing, but the opposite. But that's how it works. And so that's why there's so much like ambiguity of like what people can get paid. So if you go to, so I'll show y'all a website that'll kind of help a little bit with this. If you go, so this is a newer EMR company that also does billing. If you go to stratapt.com and then you go to physical therapy payer benchmarks, they have a live feed of people that are actually billing in these places and what they're getting reimbursed for and what units they're even doing. So like if we go to Texas, I can then actually say like, okay, well, on average, what is someone getting paid for Scott and White or Blue Cross Blue Shield or Blue Cross Texas? Like all of these different ones, so you can kind of see. The misleading thing here is if you see Blue Cross Blue Shield of Texas, you're like, huh, I thought Joey said that it was like 135 to 140. Well, the outputs can only be as good as the inputs. So if someone is trying to do 8-minute rule billing, which is not what Blue Cross Blue Shield in Texas actually follows, they're probably only doing 3 to 4 units. When in reality, if we hop in here, we could try to find someone that's done about 5 units, which here's one that did 5 units, they got 129. Another one that did 5 units, 138. And so 150 right here. And so there's a lot of these that you can actually kind of see because again, you should be able to, as long as you like just go Google AMA versus Medicare billing and kind of see the difference. You group them differently and the way you actually code is different. And that doesn't even start to factor in untimed codes or anything like that for any of your modalities if you want to kind of use some of those things. And so this is usually the first place I tell people to look because this kind of gives you a little bit of insight of kind of what you're doing there. And then every single one of your hospital systems in your area has to legally put their actual fee schedule up on their website. And so since there's that transparency, you then have their numbers. Of course, they're going to be significantly higher. They're going to be paid like 3 to 4 times what you should be expected to get in an outpatient clinic. It makes no sense. They have no extra expenses than we do, but that's just how they've kind of worked it out. So between looking at like Strata, between looking at those, you at least have some baseline numbers. Usually you can find someone in a Facebook group that'll be willing to tell you about what they're getting reimbursed. But like from there, some of them, they're very transparent. They tell you exactly what you're going to be making, or you can literally go look up a fee schedule in your zip code for Medicare. Like you can literally say, if I'm billing this unit, this unit, this unit, this unit, what am I making for 60 minutes? And so like that one's super easy. Medicare is very transparent on all their stuff. And that's why like that's where most people start if they're going
Yeah.
hybrid is they start with Medicare because honestly, like you can get in network, completely credentialed, everything start to finish as a new business in about 4 weeks based on we have full training process inside. So if you go to school.com/rehab CEOs, so school SKOOL, we have full Medicare credentialing inside of our free program. And so like if you follow that process, it takes 4 weeks start to finish. It'll take you longer to probably get on an EMR than it'll take you to get credentialed. And so they pay typically on average within 14 days. So they're very fast compared to some of the insurances. They're very easy. They tell you exactly what they want you to do. Like they pay you less for manual therapy, so they probably want you to move your people more, so they pay you more for therapeutic activity. It's like tax law. They tell you own a business, own real estate, have kids. That's what they want you to do, and that's where you get your best reimbursement or your best actual like tax advantages for. Medicare tells you the same thing. All your insurance companies tell you the same thing. Move our patients, stop doing manual. And so that may be hard for any of y'all that are like heavy manual. You're like, but we were taught so much manual. It's like, well, they don't reimburse for that. So let's get them moving. And so there is kind of a game you have to play there, but some of them you literally have to talk to them. Some of them will try to be sketchy and try to get you to sign stuff before they tell you any of the actual reimbursements. Never sign a contract until you actually see the numbers of what you'd be getting reimbursed. Because some insurance companies are sketchy. I'm not going to name names, but there are some that are very, very sketchy. And there's some of them that like they'll not really be clear on like how many units you can do. They won't be clear on like very clear on the front end. Is it capped based on certain just per visit? That's what it is, or is it's per units? So there's a lot of those things that's why a lot of people are inherently scared of taking insurance a lot of times. Or the biggest one is they're afraid they're going to get audited. And they're like, well, what happens if they recoup all my money? And in reality, like they're not really looking for a lot of the stuff that like the normal Joe Schmo is doing. They're looking for people doing what's called phantom billing. They're like billing on a Saturday and Sunday. They're billing for someone who's like passed away. They're billing for an old employee. They're doing like super like this happened up in Erie, Pennsylvania. Like they were billing like a ridiculous amount of sketchy stuff and they got closed down. Somehow there's some of them are still in practice, but um there's a lot of that stuff where like the very first thing they look is like, is the plan of care signed? Because like that's usually the first red flag that like something's going on here. And so as long as we follow like basics, like they're not going after the small guys. Like that's really not what they're going after. And like Robbie, my business partner, he's been audited, I think 3 times now. Never had any issues, but that's just part of the thing, the game. Like they go through, they audit it, and like it's really not a bad thing that you're getting audited because then now you know exactly what they're looking for. You know what they want you to do, and then you don't really have to worry about it. And so there really is no difference though, because like at any point, your payment processor could hold all your money too if you're cash based. Like that's a common thing with PayPal, Stripe, and some of these other processors that they literally just hold your money for no reason, don't tell you, and you can't get it out for 6 months. And so that can happen with any business. And so for us, I like the hybrid model because you get the big cash pay on the front end because like you get the big packages, but then you still have the money coming in on the back end. So you get the best of both worlds. Front end cash, so you don't have cash flow issues, but then you have the recurring. Because like when COVID happened, a lot of our guys that were cash based were freaking out because they had already spent a lot of the money that were the packages and stuff like that. A lot of our insurance guys, we had to like coach them to like stop going to buy crap with all their money because they were getting money from the government. They were still getting money from all their insurance claims. And like I had someone go and buy like a freaking like mansion. And I'm like, what do you like? No, that's for your business. But he never really saw the dip because he had money coming in. And so there's pros and cons to all that, but a lot of it you literally just have to reach out to the actual insurance carriers, talk to them. It's going to be a painful process. Blue Cross Blue Shield and some of those, they take significantly longer to get in. Like it's like 90 days plus on a lot of those. Like I said, Medicare is the fastest and easiest, and that's why most people go with them. The only ones that don't really inherently go with them is like maybe our guys that are wanting to work with like nothing but athletes or something like that. And it's not really their demographic. There's a lot of people that do sketchy stuff and treat Medicare when legally you're not supposed to treat them unless you're actually taking Medicare. They'll call it wellness. In reality, they're just setting themselves up for liability and stuff like that. So there's just some of those things to know, but it's honestly just reach out to them, look at Strata, look at the other stuff with the hospital systems, talk to them. But like I've got someone up in Utah that with that pelvic one that I was just telling you about, she gets full $225 a visit covered out of network by there because there's not enough providers in her area. So they're literally covering every bit of it. Like it's ridiculous, but she's out of network. And so you can do out of network in certain areas, especially the more specialized you are. If you're like lymphedema, pediatric, pelvic, some of those, you can command like a lot of the higher prices still, and it's actually covered with their out of network benefits. And then you don't have to be as good at sales on some of those things to get someone to pay as much out of pocket.
Yeah. Yeah, man. I mean, this was pretty amazing stuff. Like I said, you've hit a lot of the high points, I think, of insurance and hybrid models where it's cash and insurance. Let's open it up to questions. What do you guys want to ask? What are you guys curious about?
And I think something just for y'all to know. So when I told you all those numbers, that should set someone up for each PT to make $20,000 a month. So the blueprint really is like, and I'll draw because I think this is helpful for anybody, regardless of cash or whatever. I think just knowing this will show you a lot. So like typically you've got owner here and you're going to come in typically when you're about 75% full, because some guys they take on funding and they immediately have a front office person, but a lot of our guys are like very anti-debt because all of us have accumulated way too much debt while going to PT school. And so a lot of people try to do this like they got a part-time job, they're trying to do a side hustle, they grow this. When you're about 75% full, this is typically when you hire a front office person to help with doing some of the calls, the admin, some of the billing, some of that type stuff. So when you're about 75% full, that's when you get this person. A lot of people try to hire the PT first. The inherent issue of hiring a PT first is then you have no one to go market to fill PT number one. And so you don't have anybody to do that. So here, we'll put PT number one over here. And so if we put PT number one in here, we don't have a way to fill them because they're too busy treating. You don't have availability to actually do all the sales and to do the stuff to fill them. And your front office person, we want them to learn and get better at sales when it's just your schedule and you have higher margins. And so if we try to hire the first PT and then we hire the front office, now they have two schedules they can mess up because they're not good at sales. And then you really feel it because your first PT is really just to cover what we call our payments. So they are there to really cover your fixed expenses. That's like your front office overhead, your any building that you have, there, the PT salary, all that. And you have typically just enough actual money left over to come hire PT number two. This is what we call the first layer of true profit. This is where a lot of our guys start to try to remove themselves from treatment a little too early. But what happens is this person quits, they get fired, whatever that happens, and then you're back down here and we're like, oh crap. So we've got to aggressively go through to get to the second PT because a lot of times if you don't, You're going to halfway fill them up. They don't stay full, but somehow you're staying full and you just can't get them full. And then you have to let this person go. And so second PT is high layer of profit. The third PT is what we call the layer of protection. This is when we finally have enough money and enough actual profit to where we can remove the owner from treatment if they want to be removed. Because you should still be making, even if you're removed from treatment at this point, we should be making $60,000 a month. Because remember, each PT should be able to make $20,000 a month. And so the sweet spot that we've seen, because typically once you get to the third person right here, because one front office person can manage about 110 visits a week as far as how much actual like administrative burden they can kind of handle. So if you're doing 60 minutes, 60 slots, so 40-minute scheduling, once you get to your third PT, you've got to hire a second front office person around this time. And so once you hire the third one, you're doing $60,000 a month. You have two front office. Maybe you have a tech because maybe you need just little help with overflow or something like that. And then the fourth one, you don't need another front office for them. And so this one's just what we call our layer for prosperity. This is where we're like printing. Like this is where like PTs try to act like we can't make money inside this, but like you're printing at this point. This is the seven-figure clinic. You're making $350,000, $400,000 in profit if we're set up properly. And then this allows you to start opening more clinics, start buying the building you're in, starting to do all the investing stuff that you want to do, all this, that type stuff. Four is kind of the sweet spot because with just 7 employees, you can have $1 million clinic. You've got two front office, one of them's typically an office manager. You've got 4 PTs, and really at that point, probably one tech. Like everything else is just you kind of managing it. But 7 employees, you've got a seven-figure clinic. So I think a lot of people, when they hear like $1 million clinic, they think it's got to be like this big grandiose thing. They've seen all the like it's 4 PTs. It's not crazy. To get 4 PTs whenever we do the cash model, it is harder unless you're pelvic. The other thing that you don't inherently see on the cash side is most of the time when we're insurance based, we see people typically 2 to 3 times a week. Like that's pretty standard. And every time I ask this on my Facebook group or in my Facebook page, I say, money removed, how often would you see someone? I never, ever, ever, except for like 5% of the time, and that's usually someone who uses a caveat. I say, if we were to try to get someone the best possible results with money removed, how often would we want to see them? Very rare do I hear 1 time a week. And if they do, they say, I do 1 time a week, and all of my patients are amazing at their home exercise program, which we all know is a lie. Because I don't know about y'all, if every one of your people have been amazing, y'all got the best motivational interviewing training at University of St. Augustine that I've ever seen. Because we know that that's not true, and I know this from the dental world. I was a dental hygienist before I went to PT school. Like people don't all of a sudden start flossing. And so we realized that if we do 2 to 3 times a week, there's a lot of studies of actually getting better results because of the frequency of it. We're creating new habits. We've got a lot of different things we're doing. And if we're trying to strengthen in people, that doesn't happen with 1 day a week. Like really, most studies show you need at least 3 times a week of some type of actual strength training to improve strength. And so if that's some of the stuff we're looking at do, we kind of have to go to here. The hard part about it in the cash world is if you're charging $200 a visit, that means they're now coming out of pocket $400 a week, which is expensive for some people. And so most cash people will do 1 time a week for like the first 4 weeks. And then it gets even worse. They say, okay, well, the last 4 weeks, I'm going to see you every other week. And so the hard part about that is the amount of new patients it takes to fill a schedule when your length of stay, so how long someone comes to actually see you, is lower. The frequency that they see you is lower. The odds of finding someone that actually wants to pay $200 a visit and motivated enough is lower. It's very, very hard, and the marketing demand becomes significantly harder and harder and harder. That's why so many cash PTs have a hard time getting past this point right here, where it's owner plus 2 PTs. You can do it, but it's just significantly harder. And so that's the thing that is not necessarily seen because, like, on average, if someone's not selling a cash package, most of my guys who are selling per visit at the cash, they see people average 3 to 4 visits and then someone drops off. And if any of y'all are kind of thinking, why is that the case? Well, physiologically and thinking what we do on our actual like treatment, visit 3 to 4, you're probably getting reduced pain. They think they're good enough to not need you anymore. And so they are no longer in enough pain physically and emotionally to continue paying $200 a visit. Where cash or insurance, they are a little bit more because the bar is lower. Or maybe their doctor told them they couldn't have surgery until they came in at least 2 times a week for the next 4 weeks. Because that's actually the bar that they need so they can legally do surgery and actually get reimbursements. But that's a whole nother ordeal. And so this makes it to where length of stay, if we do cash packages, of course, it's just however long your cash package is. That's why a lot of people do in the cash world, they'll do packages because they know length of stay, if we don't do it, is very, very low. Not to say that you can't have insurance clinics that have very, very low length of stay, because like if we don't educate people, we don't know how to talk to people and then really emphasize the importance of all the things we're doing, they'll drop off just as much too because they have less actual like skin in the game. But most of our clinics that are insurance based, they're typically in the range of 12 to 16 visits for a plan of care. And so since that's longer, it means they have less that they have to come in because there's retention of patients more because they stay longer. They come in more often, so they fill more of their available visits. So you just need less new patients. And you're already getting referrals from physicians. And so that's why we look at these things. And so if you're just looking like, I want to grow something, help as many people as fast as possible, get out of treatment and just print money, I tell you go hybrid. Like I've got guys that are making more in profit than most guys are doing cash in revenue. And ultimately revenue doesn't matter. Like profit is what matters. And so sometimes it's just because they've had such a bad experience in the insurance world, they think they have to lose their identity of someone who actually cares taking care of people to take insurance. But you really don't. Like you really don't at all. And so the last thing I'll say before we get into questions is like all of us went to PT school, I assume, because we wanted to help as many people as possible. Is that why most of y'all went to PT school? Like, hey, I like being active, I like the exercise stuff, I want to help as many people as possible, and going to med school sounds awful. Like that's probably the reason that y'all all went to PT school. And so it's kind of incongruent when you hear someone say that is why they went to PT school, but then they simultaneously say, only if you can afford $225 a visit. And so when we say that, it's not congruent with anything we're doing it, which to be fair, I've got someone in Florida. He charges $225 a visit, but he has a nonprofit where he actually treats patient for free, essentially just covers the costs. So he actually does what he meant to do. He charges high ticket so he can afford to do the nonprofit. And so you can do it. It's just know what you're doing it for and know that you can do it either way. What questions do y'all have?
Yes, I have a question. As far as for a new grad, what would be the best way to learn about insurance?
Uh,
Like any resources or anything like that, or is this just basically off experience, work experience?
when you say about insurance, is this for like actually billing? Is this for potentially
Yes.
taking it or?
Billing. Just yeah.
Yeah, as a like a staff PT, there's honestly, sadly, not a lot of resources on actual billing. I think it's probably one of the most underserved because the hard thing is most students don't care about billing until they need to care about it, and it's already too late. Because even for me, I remember we went through stuff in our school and they taught us some of the billing stuff, and I was just like, this is awful. I don't care right now because I don't inherently understand it because I'm not applying it right now. And you kind of learn a little bit when you're doing outpatient and stuff like that. A lot of it is trial and error, and hopefully you have someone that you're working for that is educated on it, and they should continue to actually educate you on there. There's a group on Facebook. It's called Physical Therapy Billing. It's just literally filled with nothing but billers in there and clinic owners. It's like the nicest people there, or the Medicare. What is Tony's group, F. Scott? Medicare. It's like Medicare billing for mostly cash-based providers or something like that. Those two groups, you can literally ask any question. It's like the nicest people you'll ever run into, and they'll walk you through anything you'd ever need to know on the billing. But just be aware there's some people that are trying to help, but they don't know what they don't know. And so take every answer with a grain of salt because I've had several people who like didn't take insurance because someone told them like, oh, well, like it doesn't reimburse well. And it's like, well, what state, what plan, what like there's too many variables there. And people will just blanket like, oh, like Aetna sucks. It's like, well, where? Like, does Aetna suck everywhere? And so like that's just as important. But those two groups, like I said, I'm sure F. Scott can kind of find those links as we're kind of looking. But the physical therapy billing group, and then there's one that's Tony Maritato is the one that runs the one for Medicare, and he offers some stuff on credentialing. And again, and if you go to school, so skool.com/rehab CEOs, we have some basic stuff around like just the billing side, but we have full credentialing and full everything in there. And we do 2 free group coaching calls a week in there too. So like you can literally hop on, ask questions, do whatever. That's just free to the public. It's like we don't even work with people on like a one-to-one coaching basis until you're owner, admin, PT, and doing $30,000 a month in revenue. Like we just want to help as many people open clinics as possible because we know right now, if the profession continues going the way it is, no one will want to open a clinic. And so we wanted to lower the bar and lower the friction for someone to open. And then, of course, if you get big enough later on, maybe we provide enough value. Cool. Like we work with that person. But we can't work with everybody one-on-one. So we just want to provide as much as we possibly can there. So there's not an easy answer there. I wish there was someone that taught it better to the students and some of that type stuff, but some's through trial and error, some's through asking questions, but a lot of it's through like not being afraid to ask a question and looking dumb. It's okay. We're all dumb on this stuff when we first started. Like we are not taught it at any means. Like it doesn't matter how good your school is, no one teaches it, or when they do teach it, you're not really at a point where you care enough to learn it, or you're not at a place to actually apply it. It's like when you go try to learn Spanish in high school, but then you're not around anybody that speaks Spanish. That's why you never learned it. You had no place to continue to actually do it. And so once you do that, you'll have it. Same thing with sales, like the amount of people who read sales books and then they've never actually done the interaction of trying to sell. They have no context of which to apply it. Right now, you may have no context of what to apply the billing side of things. But as you do more and more, you'll learn. But the big thing is learning as you get denials of any type of thing, because like sometimes they'll be like, oh, you can't use that specific code whenever you do an eval, or they only reimburse this. Start making an actual like Excel spreadsheet and then say, hey, Aetna, they require this. Make an Excel spreadsheet. So the next time you don't have it mess up. Because a lot of our times when people do billing, they're like, oh, I've got so much money in collections. I'm having to chase people down. This is why I hate insurance, blah, 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 blah. And it's because they don't fix the stuff on the front end. It's like the person who's at the end of the year and they're like, all right, like it's time to figure out how we can mitigate taxes. Well, like we already missed the boat. Like we should have done everything before the end of the year to actually mitigate all those taxes. If we're after the fact, we're already kind of screwed. And so your outputs can only be as good as your inputs. So like start to think about those things. And a lot of times if you go work for a clinic, they're not transparent about that stuff. But if you go to them and say, I want to make sure that all of my stuff is passing, we're not having denials, they will love you forever. And so ideally, that clinic should have a 98% first time pass rate. So what that means is if they have 1,000 claims based on the visits they're doing, 980 of those should pass without you having to do anything or them chase anybody. Because then at that point, they only have to chase 20 out of 1,000. But what normally happens is they have like an 85 or 90% pass rate, and then they're chasing 100 or more people. And then they're like, we have cash flow issues. But if you can fix the stuff on the front end, they'll love you and they'll like, trust me, like if you can make sure you fix this stuff and you optimize even the people that you work with, you will get promoted very, very quickly. Like that is the fastest way to get a promotion in any outpatient clinic is find ways to make them more money, find ways to systemize things, find ways to decrease the administrative burden. If you can do that, you'll be a clinical director fast. Like the bar is low. Like there's a lot of lazy PTs out there. So like the fact that y'all are even here tonight already says that y'all are significantly further ahead of a lot of people. Like, and I'm not saying that just because like y'all are truly, there's a lot of people that would not be spending the time to show up, ask questions, not know these things. Because there's a lot of people that'll be 3 years down the road, haven't paid off their student loans, and then wonder why the government hasn't started to help paying for them. Instead, y'all are here trying to figure out either how can I start my own business or how can I be a better employee so people compensate me more? Because that's all business is. You provide value, you get paid for it. You provide more value, they pay you more for it. You just continue to find those things and you'll continue to get raises. Is that helpful?
Yeah, that was good. Thank you.
Sweet. What else we got, guys?
Joe, I got a quick question. I think, my bad. Let me hop on real quick. I think I've just been a little confused with this out of network setting.
Yeah.
So how does like a physician referral and like direct access play into that? do we kind of disregard, or is it still something that we adhere to?
Everything will go back to your practice act, almost across the board. So like if like in Texas, if someone comes in, you still need to get the physician to sign stuff off for Medicare. You still need to get the physician to sign stuff off after we're past our, I think it's 14 days in Texas. Like you have to get all of those things done. So like a lot of people think like compliance goes out the window, all the direct access stuff. Like it's the exact same thing. We should operate in network the exact same way from a compliance standpoint as out of network. A lot of cash guys will think they don't need to follow anything around HIPAA. Like you need to follow stuff around HIPAA when you're cash based. And so nothing really changes, like almost at all. The only thing that really makes it a little bit easier is like some of the insurances will make you do pre-authorization and shoot through more hoops before you can start to see them if they're in network. You may not have some of those restrictions from when they pay you, but everything still goes back to your practice act and what you have to make that work legally. And that's why it's kind of broad because like it's different in Florida than Texas. North Carolina has been like you do whatever the heck you wanted for the last 20 years. Like they've been direct access forever. You got New York, you can't do dry needling. Like there's all kinds of different like weird things in each place. So practice act is what rules all. And then from there, treat everybody as though you are in network as far as your compliance side because it'll always be the most coverage across the board. Like, don't get lax thinking you have to do less notes because you're now cash based. Because ultimately, if you're not doing your documentation, nothing's going to hold up in court. If it's not documented, it didn't happen. And sometimes that is what gets you is you don't have documentation. So treat everything exactly the same. Does that answer your question?
Yeah, no, totally.
So
But then I think I'm still a little lost. So if I am out of network, I'm still dependent on like a referral system from physicians in the area.
No, so you are dependent on them to sign off on a plan of care or depending on what your direct access is. But like I've got guys, we run Facebook and Instagram ads. Someone comes in, they have back pain, you can see them. But
Okay.
again, it depends on your direct access laws and some of those type things. So like
Right.
it depends on what you're classifying as out of network. Like out of network, are we talking, hey, I take your money and I give you a super bill? Or are we billing on behalf of them for out of network benefits? If it's like more of your strictly cash based on providing a super bill, like you don't have to worry about any of those things as far as like, oh, like they need to sign off on this. If your state practice act does not require it, you don't do any of that stuff. And so you just kind of have to look at state practice act, and then from there, that kind of dictates it. But I've got guys who just literally like turn an ad on for Facebook and Instagram. You get a lead that day. That person could literally come in same day or the next day. You don't have to go to the physician at all. But if we get into Medicare, you can't do treatment until the physician has actually signed the plan of care. And so you can do the eval, but then you can't do the treatment and you have to hold off everything until you get that back. And so Medicare is a wonky one, but like that's kind of some of the stuff you get at. Or like in Texas, I know if we have like I think it's if you're fellowship, you get like an extra week for your direct access or something like that. So like it's all kinds of crazy and all changed kind of across the board. And so state practice act, but no, you like if it's truly like a cash-based model, as long as you're not breaking your direct access laws, you can literally have them come in, pay you $2,000 for a package, and you're good. Like you don't have to get anything else. And that's why
Gotcha.
a lot of people like the cash model is because like there's less of those restrictions there. But then there's the other restrictions of marketing and sales and all the other stuff. And like a lot of times the owner is very good at sales, but now they have to find someone who's one, competent at actually treating, two, that knows how to communicate to people and sell. Those are two hard things to find. It's already hard enough to find a PT right now. There's a shortage of PTs. So finding someone that's good clinically and actually is good at sales, it's tough.
No, that helps. Thank you.
For sure. And that's the other thing. Like it's running a business that's efficient and profit. The reason that is so important is because if we truly want to pay staff therapists the way we want to, you can't do that if you're not profitable. Again, I've literally never met an owner who says, I don't want to pay my PTs more. The reason they don't is because they have a bad business and they can't afford to. And so that's why we want, and that again, that's why we bake in like 86% clinical efficiency, we no show, all that type stuff. Like we want to have money because like everybody wants to pay people more. And if you can pay above market value, you're probably going to get the best PTs too. And so that's why we look at those things and we want to be set up right. And so again, we just want to look at all of the factors. And so that's why I can never tell you like, hey, you should go cash versus I should go hybrid. It's what do you want out of your business? And then as soon as we know that, and that's why like in some of our trainings in that group I was talking about, like one of the very first thing is like figuring out your why, figuring out what you want out of it, figuring out the big important things, because all business is hard. If someone doesn't tell you that business is hard, they're probably selling you something. And so if all business is hard, we need to have a big enough reason of why we're doing this. So that way, when we have those crap days, you still stand up and keep going. And that is very, very hard because some people are like, I'm just in a place if I'm broke and I need to make some money. And then that's usually not enough because eventually you're going to have a couple of those hard days and you're like, I just want to throw in the towel. And I've had probably 7 people now over the last 2 years since we've kind of started walking people through some of the beliefs and the figuring out your why and some of those things. They go through that more of like the mindset training that we do. I've had 7 people now go through that and realize I don't think it's something I want to do. And they actually close down their practice. Like, and that's okay because not everybody is meant to be an entrepreneur. Like, I really don't think so. Because if everybody's an entrepreneur, who works for them? And so we have to have both of those things. And so just figure out what you want. And for some of y'all may actually be better entrepreneurs. So that's, you don't want all the inherent risk of owning your business, but you like to build cool stuff. You like to be a part of a team. You like to have big growth goals, but you maybe don't want all the risk of ownership. So you may be an amazing clinical director. And so just thinking about those things, you still have upwards potential there. And then like a lot of people, they get you into a clinical director role. And then from there, when they open a second location, you become a partner. You can't do that with a lot of the big chains out there because they want all of it and stuff like that. But like, that's not uncommon. Like they'll say, hey, we're going to own 51%, 49% available in the second location, cost $100,000 for us to open. How much do you want to actually put in? And then based on what you put in, if you put 20,000 in out of the 100,000 it requires, you're now 20% owner of location 2. So then you have the upside without all of the downside. And so there's a lot of owners that are looking for operators, that are looking for COOs, that are looking for clinical directors because either they love treatment and they don't want to get out of treatment and someone needs to run their business, or they want to open multiple locations and they have to eventually scale themselves. And so don't think that you always have to be the owner. There's a lot of options for you to make a lot of money, help a lot of people, and continue to level up your skill set. What other questions you got?
So I was wondering, so you were saying like, there's differences between Texas and Florida. Dr. Phil said like Washington State has way better reimbursement than like New Jersey. So like what kind of dictates the states like how their reimbursement goes? And like is there any way that like does that ever change over time? Or like does anything
Yeah.
kind of,
No,
affect those things?
Yeah, no, that's a good question. So like up in the Northwest, there's an actual committee that actually fights on behalf of the people that are there. There's an actual compact of guys. So the guy who he's about to retire, but the main guy that's over that is Rich. His name is Rich Katz. It sounds like a villain from a movie or something, Rich Katz. But he's been around and he's been doing this for a while. And so he's been the one and some of the people that are associated with there that have fought for those to not continue to decline like a lot of the other states have. He's tried to help put some of these actual like initiatives in place across other kind of different like across the Northeast and across the central kind of areas and all there. They just haven't been as effective. And so for like Alaska, average reimbursement's 225. Like it's ridiculous. They've literally never had a decrease in reimbursement, like ever. And so there's supply and demand. That's a lot of it. There's people who are actively lobbying and fighting for it. And there's just some areas, like sadly, there's some states that are just kind of not good in general for business. And that already kind of inherently kind of puts us in a bad state. So like nothing against anybody if y'all are from New York, but like New York is probably one of the worst places. Like I would never open a clinic in New York. I've got guys that are doing 300 or $30,000, $40,000 a month in profit. So like I've got guys that are doing really well. They're all out of network. Like they only maybe take Medicare, but they're all out of network because all of the actual contracts there are like garbage, like really, really bad. And so between that and the actual like high taxes in that state in general, it's very, very hard to make it work unless you're a good operator. California is tough to work in as well. You can at least kind of stay in like the 95 to 100 with most insurances in that area. But it's still a little bit tough. But again, like Texas is really good because we've got average, you can probably stay around like 110 if you take a good majority of your insurances. And that would mean you do 40-minute scheduling. So it's not like too crazy high volume. It's very good. Like it's pro business. So like tax wise, it's really good. So those are the other things you think about state wise. It's like Florida and Texas, they're very, very good business states. They're very pro business. And so from a tax standpoint, a state income tax and all of those things, they're very good. Washington's more expensive to live there. So that's some of the other factors you have to think about of like, okay, it's 150, 160, but cost of living is like 2 times what it is in Texas. And of course, it depends on where you are in Texas. Austin's significantly different than like going to like some random place in like West Texas. So like where you are matters as well. And the other thing to think about is when you're opening clinics, how close are we to the closest PT school? Because a lot of times for our big guys, that is the bigger bottleneck is hiring, not actual marketing. And so if you're in the middle of like 5 hours away from the closest school, like I've got someone I know that's in one of the border towns of Texas. The only thing that she has there is PTAs that are close. The closest school to her is like 4 hours for PTs. And so you eventually hit a limit because there's also like legalities on how many PTAs you can have in different states. Like you can only supervise so many PTAs as a PT. And the inherent bottleneck is if you only have PTAs, you have to become the evaluation machine for all the PTs or the PTAs. You can't go on vacation because their schedule doesn't stay full unless you're there doing evaluations. And so thinking about those things also matters, but a lot of it's due to lobbying. Unfortunately, a lot of our like kind of like bigger actual organizations have not been amazing on the lobbying side. I don't think that's necessarily for a lack of trying. I think there's also the factor of like we also have other people lobbying against us that have significantly more money. This is the same thing that kind of happens in the dental world. So I was a dental hygienist before I went to UT Southwestern for my DPT. In hygiene, they were always fighting to get more power for like doing local anesthesia on someone or doing some of the other stuff, having less supervision. So that way a dental hygienist could do some of those. Well, they always had to lobby against dentist. Well, who do you think has more money, dentist or dental hygienist? And so who do we think has more money, physical therapist or physicians? And so that's the inherent thing that we're kind of fighting against. So it's sometimes not even like a, hey, it's the APTA's fault. It's like we're fighting an uphill battle. And that's why I think realistically, the way that we can make the changes we need is people like yourself who are wanting to open up practices to start to do it, to make the changes, and also still be part of the APTA. Because like we have no right to complain about the APTA if you're not even a part of it. Like you literally, you gave up your right to complain if you're not part of the APTA. Even if you don't think what they're doing is right, you still can't complain about it. Because otherwise you're just bringing problems and not solutions. And that doesn't serve anybody. And so I think the other way is like physical therapy, like we have a branding issue. Go stop 10 people on the street, half of them are going to tell you different things. They're going to say, oh, you only work with people that just had like some type of car accident. Oh, you train people, right? Oh, you work with athletes. Oh, you work with people who had strokes. Oh, like they don't know. And so PT as a profession as a whole, we have a branding crisis. And it doesn't matter how many billboards we buy in Times Square, that is not going to change it. It's going to be all of these local businesses doing their own advertising, showing people, educating people, letting them know what we do. And then and only then will we start to have some type of ability to negotiate pay with insurance companies. And the other issue is we're so tied to so much of our like, oh, I'm a Maitland person, I'm a McKinsey person, I'm a this person that we're fighting against each other of like, this is the one that works, instead of actually having conglomerated actual evidence to show why people should be paying for insurance. Like, so instead they just cut us and then they keep paying the physicians for the back pain surgeries that we know don't work. And so I think the more we can focus on like truly raising each other up as a profession, like that's where we're at. the thing that people aren't seeing as well, like I have a lot of chiro clients, like I've got like 5 chiro clients right now that all have physical therapists on staff now. There are 4 times as many chiros as there are PT clinics. So if chiros are seeing the opportunity with physical therapy, all of these physical therapy clinic owners are going to have their lunch ate because they see the opportunity. They want to continue to do it. And so if we don't do it, they may at least maybe help us, but if not, we're just going to completely bleed out as a profession because chiros are going to take it over. We're just going to be an adjunct service for them. And so we have to continue to push this stuff. Otherwise, like reimbursements will continue to cut. But the good thing is, if you understand sales, you understand marketing, worst case scenario, you go out of network with someone that starts to pay you less and less, and you can still be profitable. And so that's why I'm not scared about where any of the insurance reimbursements are going, because I've got guys that are 100% cash based doing 7 figures. I've got guys that are insurance based that are multi 7 figures. Worst case scenario, you cut an insurance. Your average reimbursement goes back up and we're good. Because there's still going to be more people that need it. Like the physical therapy profession is a $43 billion a year company or industry. It's going to be 92 billion by 2030. So if there's a decrease in demand or decrease in supply of physical therapists, there's an increase in demand. That's pretty good economics for us to be able to charge more. And so there is a lot of money to be made and a lot of people that could be helped. And it's okay to make money in healthcare for any of you that need permission. Like money does not change a person. Money amplifies the person that we are. Good people give back even more once they're rich. Evil people just become more evil. And so if you're a good person, the more profit you have, the more you're going to give back and the more people you can help. So it's okay to make money. What other questions y'all got?
Good evening. First of all, thank you for coming on and talking to us. This has been extremely helpful. Could you, sorry for spelling purposes, drop the name of your the program again? I apologize. I know you said it like 3 times.
You're good. I just dropped it in the chat. So it's school.com/rehab CEOs. So there's a lot of, I say you're welcome. I say there's a lot of stuff around like marketing. So it's like got our full sales stuff, full workshop stuff. We got coaching calls in there. You can ask questions. Like there's a lot of those things. There's like 350 videos. Like it's kind of overwhelming when you first go in, but like there's a lot. Like we used to charge $1,000 a month for like a good majority of that stuff. But then we realized that like startups, if y'all have money, it should be spent on hiring. It should be spent on hiring and marketing. That's it. Because until you're kind of at our threshold to work with us on one-to-one, like that's all your effort. I need more patients. I need to know how to sell them. I need someone to help me because now I'm full. And once you get to bigger, then we can start to get into systems and operations and hiring and all the KPIs and all that type stuff. But most of the time, that doesn't matter when you first start. It's like, I just need more people to know I exist. Like that's usually the bottleneck when you first start.
No, absolutely. And thank you so much for that as well.
Yeah.
I had kind of like a 2-part question. So the first part, in regards to $95 an hour in Texas, what was that based off of again? I apologize for missing it earlier.
So $95 average reimbursement is essentially like here, I'll show you. So that's more so just what we need to be at to actually maintain the certain scheduling. So for 30-minute scheduling, if we're below 95 average reimbursement, we have to do 30-minute scheduling. So you'd see 16 people a day. If we're between 95 and 140, which is pretty much what we'd fall into in Texas, you would do 40-minute scheduling. So again, this is 60-minute sessions, but every 40 minutes someone comes in. So there's a lot of one-on-one with a little bit of overlap. And so you'd be able to see 12 people. And if you're above 140, that would allow you to do 60-minute one-on-one and you only have to see 8 a day. And so the other thing that kind of applies here though, is these numbers can actually change a little bit if you want to go like super, super high ticket. Like I've got someone that charges $350 a visit. They don't need to get to where they can still make $20,000 a PT. They don't need to see 8 people a day. They can see significantly less. And so for them, if they're charging $300 something, like they could see like 4 people a day. That's it. And so like if you want to go like super niche, because I've got guys that are like some only work with chronic pain patients, some only work like I've got one that like works with just like nothing but pickleball players. Like there's some of these like super crazy niche, like they only work with dancers, they only work with like I've got one that works with a lot of like pro athletes and stuff like that. So like if you want to go super niche, charge to be super niche. Like because the issue we run into is like you've got someone who wants to work on only Ferraris as a mechanic, but they're charging the pricing of someone that works on Hondas. And so there's only so many Ferraris where Hondas like you can make up in volume. And so just make sure we're always charging accordingly based on what you're wanting to see. And that's why like just deciding what you want out of your business is what is really important. If you're like, hey, I just want to stack $200 a visit or $300 a visit and work 2 days a week and just live a cool lifestyle, you can do that. Like there's a lot of people that do that. But the hard thing is if we ever get to a point we kind of plateau and don't want to continue growing, this is called the growth success curve. There's kind of two options. We can either kind of come down here and then it goes back up, or we can go down here and then we start to fall. And so if we plateau here and we don't continue to grow, this is where like a lot of your A players, like your rock star employees, if they don't see you have a big enough vision that you're trying to grow up here, they all quit. And so if you try to stay small, you'll always stay small, even if you do, even if you try to change your mind. And so we always like that's the whole like I want to have a vision big enough for someone to be able to fit their career inside of it. So like that's why like for us like we want to open hundreds of clinics. So like if you can't fit your career in there, like I don't know what kind of career you're trying to have. Like there is a lot of opportunity there. But it is very common for our guys who are like, I just want to grow to a certain spot and then kind of automate and live a lifestyle. They're good for a couple years. And then this high performer that was an A player starts to become a B player. And you're like, what happened to Susan? She's not amazing anymore. And then we either have a conversation with her and she quits because she realizes nothing's going to change, or we can start to try to grow again. And then Susan realizes she can go open a clinic over here with you. Or she says, I don't want to do this. I'm going to open up a clinic and be a competitor. That's very common. And so that's kind of what it is. So 95 average reimbursement to 140 is really kind of where it's important. But when you're looking at Texas, like I said, most of the time you're going to fall into like the 110 or somewhere around there. But again, it depends on your payer mix and kind of where you're at. And that changes even city to city. Because like you may have like in Texas, 24.5% of your insurance base is Blue Cross Blue Shield, which is good because that's our best payer. And so in most areas, Blue Cross, especially a lot of your like Dallas, Austin, San Antonio, like it's very heavy Blue Cross Blue Shield. But if you get into some of your more rural areas, they may not have quite as many of those, and you start to get into more of your like your Cigna, your United, and some of those. And those are not like most times they're not as good. But again, look at stratapt.com, go down to the bottom, go to your payer mix, and you can kind of see at least some of those to get an idea on some of that.
Absolutely. So within that 95 to 140 range, you do 40-minute sessions. You can see up to 12 patients a day and get that reimbursement. And if you sustain that, a PT should be making for a PT making 20K a month.
Yeah, because so I'll show you this real quick. So I think that may be helpful for you all to kind of actually like visualize this. So if we say, okay, we've got let's say for 40-minute sessions, we can see 12 a day. So that means you're going to see 60 in a week. So then if at that point, if you do 60 times 95, that ends up being roughly $5,700 a week. So you times that by 4.2, because that's about how many weeks you're looking at on average in a month. That gets you to 23,940. You then times that by 0.86. And then that gets you, because 0.86 gets you to 86% clinical efficiency. So assuming we're going to have 14% no-show cancellation, that gets you to $20.5 thousand, 20.6 if you round up actually. So that's how much money you'd make in a month, only being 86% full, as long as our average reimbursement is at least 95.
And you're saying that's how much you would make for the business.
Yeah, that would be the revenue. That would be your revenue. And so typically on there, as companies grow, typically their operating expenses stays around 65%. But if we see that, like, again, if we're looking at that, if we're 86% full, we should be set up to make 20% in profit 10% in an opportunity reserve. So that's like, hey, I want to hire someone, I open a new location, or hey, God forbid we have COVID 3.0 at this point. Like, and we have shutdowns, that's more of our oh crap fund. Like that's kind of what you'd use that for. And then if you're set up as an S corp, which most of our guys are, once you kind of get to different distributions on tax stuff and everything like that, 5% is about what most of our guys save of the revenue for a tax reserve as well. And so this allows you to be here. So if you're above 86% full, then you make more profit. If you're above the 95 average reimbursement in this situation, you make even more profit. So you can make significantly more than just a 20, but we try to get it to where at a minimum you're 20, because the rule of thumb is when in doubt, remember the year 2013. The reason I say that is each provider should be making $20,000 a month. And if we do our expenses, essentially, so let's say we have, for this scenario, let's say we have 3 PTs. You should be able to make $60,000 a month, and the expenses that you should never be above, or you actually have a true like bloated expenses issue, is $13,000 per PT. And so that means for 3 PTs, we should never be above $39,000. And so the reason we do that is that buffers in $7,000 of profit per provider. And so this is important because I'll have guys, like, it doesn't matter how big they are. I can like walk them through this stuff, and like almost across the board, like these numbers should be pretty dang accurate. Like when we do this, they're like, oh yeah, like you're close, but like my expenses are actually 38,500. Like it's usually pretty dang close. Or in this scenario, if they had 3 PTs and they're like, well, my expenses are actually 45,000. They may not actually have a revenue issue. They truly have an expense issue. They're overpaying someone. They have billing issues. They've got like, they're like, maybe they're paying 8% for their billing instead of 6% or 4% or whatever that is. Their rent's really high. Some of these guys will do stuff around like performance-based pay for their staff. So they're like paying them based on units or visits. And then like at scale, it doesn't make sense and they're losing money on it. And so sometimes we have to restructure pay because what they did when they first started doesn't work now. And so as long as we're around here, then, okay, well, the question becomes is, are we making $60,000? And if we are, then we've kind of maximized it. And if we're not, and let's say we're only making 40,000, or either that means we're not set up properly. So an example of that is, let's say we're doing 95 average reimbursement. Well, maybe we're still trying to do 60-minute one-on-one. So we physically can't make enough money because when you look at the average available slots times what we're getting paid, it will never come out to this. So our math ain't mathin'. And this is like, it sounds common that this would make sense that you'd be able to see this, but like the amount of people that I've talked to who are like 20 years in business, or like, I haven't paid myself in 20 years. My husband is the one that actually pays, or my wife is the one that actually floats everything. And it's because like literally like those numbers, $83 average reimbursement. I had someone doing 60-minute one-on-one and they had 6 PTs. And their gut reaction was always like, let me hire one more. Maybe I'll be more profitable finally when I hire one more. And then the math doesn't math again. And then they wonder why there's no extra profit. And then now they just have more headaches. And that's when you fall into someone saying like insurance or clinics don't work. It's because they're set up wrong. So if we're not set up right from a average reimbursement to the available slots, that's one thing. Or maybe we just need more new patients. Like we need more people. And that's the other thing to look at. Or maybe sometimes that means we're actually underbilling. And which I know for a lot of y'all, when y'all think about like insurance clinics, you think about people grossly overbilling. And that's what some of the sketchy ones do. But like most therapists underbill more than they overbill, almost across the board. And most therapists overdocument instead of underdocument, almost across the board. And so there's a lot of that because we've been kind of like feared into all this as we're students and stuff like that. It's like, you've got to do all kinds of this, don't overbill, don't do this. And then like we're leaving money on the table, which then is also kind of a feedback loop to the insurance companies. Because if we're telling them, hey, we actually only need like 3 units for this hour, well, then they want to start to pay everybody around what they're used to paying for that visit. And so it lowers the bar because there's the feedback loop of like, well, if I was able to pay these 20 people this, why can't you accept that? And so the more we actually start billing appropriately, they'll start to see that that's actually what we need. Is that helpful? Does that kind of walk you through what I'm talking to on the numbers there?
Yeah, that was super helpful. I really appreciate it. And as the last quick question, I just finished the public health course, so throughout this whole chat, I'm like, yes, success. So I was asking, with all the gyms and stuff that you're helping clinics out with, does this apply to uh, home PT, not like home health, like medical necessity, but like home physical therapy, as in like somebody just wants you to come to their house to do their PT, even though it's not a medical necessity. Like, does
So
Sounds
that
fair.
more of like your wellness kind of back end stuff. So more of cash pay is what you're saying?
yeah, or is there even like, does insurance even cover that? I know like in a lot
So
concierge. Thank you, Jose.
yeah,
Yeah, I
so
don't know if
for
insurance even covers that, but
yeah, it does. All you have to do is essentially change the modifier of where the location of the outpatient clinic is. This is actually what F. Scott did with his for a while down in Waco. And so it's a very common model for people to start out with because your overhead is pretty much nothing. And so without you having to get into a subleasing space and stuff like that, because like a lot like your options are pretty much you get a big facility that can have multiple people. You sublease in a small space. Usually it's like a couple hundred square foot. That's like in a gym or another like facility functional medicine doctor or something like that, or you do mobile. And so all of this applies for there. The hard thing about mobile is typically the most you're ever going to see in a day is 5 to 6 visits. And so when we start to get into like available slots and some of that type stuff, the inherent bottleneck you run into is if I can see, let's say because we'll say Texas, we'll say like $110 average reimbursement, something like that. Even on the max, you're probably going to see 6 a day. If we do that times 5, then you maybe will see 30 in the week. Okay, well, if we are in an actual, like, let's say just inside of a gym and you rented a room and you just have enough for a treatment table, if you're doing 40-minute scheduling, you can see 12. And so at that point, you can now see 60. And so the thing to think about here is a lot of people will tell me that it's too expensive to sublease a space. But in reality, like a room somewhere in Texas, like 1,000 to maybe 1,500 is like max of what you're getting, unless you're in like a bougie area in like Austin or something like that. Like, and even then, probably not that much. And so if let's say we're averaging like 110 average reimbursement, okay, well 30 times 110, that means every single week you actually have a availability of making an extra $3,300 per week. If you times that by 4.2, then that allows you to make an extra 3,860 for the entire month. So $1,000 to $1,500 is very cheap when you realize it allows you to have the opportunity to make this much more. And so we have a lot of people that do mobile to start. Eventually, you'll want to transition to having your own if you're wanting to grow something bigger, because the logistics of it, if you start getting like staff and stuff, the turnover rate's significantly higher because people don't like to drive and the wear and tear on their car. You don't have time to do documentation when you're going back and forth. You don't want to go into some of these homes and stuff like that. There's some of that issue as well. Or if you're female, there's a lot of inherent like security issues around some of that side of things too that we have to kind of consider. And so, not that guys can't get beat up too, like there's some sketch people, but I'm equal opportunity here. Guys can get beat up too. And so like there's a lot of those things that you can kind of look at, but like that's why almost across the board, it always makes sense for us to have our own physical location. And from a marketing perspective, like you can't really rank from a Google My Business listing of like your maps. If someone searches physical therapy near me, someone who has a brick and mortar location is significantly more likely to rank than someone who's mobile who doesn't have a physical location. Because one of the ranking factors is proximity to the person searching. So how close you are. Well, if you don't have a location, you can't be close to them. And so brick and mortar will always have an inherent advantage for that. And so that's why most of our guys, they do this to start because like you can do like 1 day a week or whatever, because maybe you're doing like 4 10s at a hospital or something like that. And so as y'all are all thinking about opening your own location, whenever you start working at your first place, make sure they do not have a non-compete. Or if they do have a non-compete, make sure that it's not going to be based off the actual setting. So then maybe you could do an actual home health place, or you could do an actual hospital place. So then you can actually open up your own brick and mortar without them firing you because they think you're going to take all their patients. Some people are super chill with it. Like I've got guys, they're like, oh, we're in network, like you're doing cash. Cool. Like, I don't care. None of our guys are going to pay cash, even though they would, but like they don't inherently know that. And so just think about those things, but it's all applicable for mobile. You just kind of get into the bottleneck of like 5 to 6 is about the most you'll see per day if you're doing mobile.
Yeah,
And it's
the in hindsight, I mean, it goes back to the why that Joey talked about. I did it because I wanted a lifestyle business where I can make some extra money on the side, not have to deal with insurance because I needed the benefits, the medical benefits of a 9 to 5. It fit my schedule nice because I was already doing home health. There was no crossover because home health was all Medicare. My patients were all CEOs and C-suite level exec type busy businessmen and businesswomen. So it was like two different populations. There wasn't
Yep.
any sort of compete. But in hindsight, I definitely would have probably started, if I was going to do just my own thing, a
Yeah.
brick and mortar, and I would have tried to own the building and made it more of a real estate play too,
Yeah.
in hindsight. But
Yeah.
it worked
Yeah.
out.
Yeah, once you get into the other, like when you get to really filling clinics, having heavy profit, then yeah, you start thinking about like, hey, we're going to buy the clinic. Because then the cool thing when you start getting into buying clinics and opening multiple locations is a lot of these people that are buying up all these clinics, they don't care about the actual property that it's in. So they'll buy your clinic, and then from then on, you now have an actual tenant that's going to pay you the recurring actual rent on it. And so you sell for the big 7-figure multiple, and then you still have passive recurring revenue from owning the building because now like healthcare is like the best kind of tenants because they stay for forever, they don't ruin everything and stuff like that. And so you kind of have that built in and you already know if you can trust the staff because it was your staff.
Yeah.
And so like it's where a lot of our guys are kind of transitioning as they kind of get bigger and bigger is like, okay, now we either buy the clinic we're in or we open in another place right down the road so we can own it. And so there's all those things, but like I've got someone right now I talked to last week. He's in the Houston area. He's working 40 hours a week in a hospital setting. He's still doing 25 visits a week on his own doing mobile. That's like hardcore grind. Like most of our guys tell me they're booked out at 25 and that's their full-time job. So that doesn't mean you can't see a lot of this. Like he's ridiculous. Like he's working weekends, nights, everything like
Yeah.
that. But he's like, I don't want student loans.
Yep.
And so he's just aggressively doing it so then he can open up his own place. But even him, he's like, okay, like I'm kind of looking to see if I can find a place to open. So like a lot of that will start to apply. What does renting a space out of a gym look like from a negotiation? So, on the negotiating stuff, there's different ways to do that. Some of our guys will do a per visit rate, and then some of our guys will do a monthly rate. Some of them will do a per visit rate that's capped at a monthly rate, or sometimes it's a monthly rate that's capped there. You have to be careful on the per visit rate because you kind of get into some gray area on kickbacks of like technically you're paying them every time you see a visit kind of thing. So you get into some weird gray there. But usually the per visit or the per hour is kind of the normal one that a lot of people try to get into first, but you want to make sure there's a cap on it. Because what happens a lot of time is the gym owner sees as an easy way for them to actually like make money because they're like, oh, I mean, I'm not using the room anyways. And then they see you start to get busy and then they want their cut. And so as long as you cap it, it's like, hey, like I'll do $30 a visit, but or whatever it happens to be for you, because it's different area to area. It's like, all right, I'll do 20, I'll do $30 a visit, but like I need this to be capped at $750. And so that way you kind of at least can control for expansion actual expenses. So it's a lot easier for you. But like that's kind of stuff you get into. But there's a lot of options to rent inside of these places because the average gym owner only takes $30,000 or $30,000 a year home. They are like grossly under profitable. And almost all of them work 60 hours a week or more. And so most of them are looking for ways to have more kind of passive income because they're usually not profitable to start with. But the hard thing about that, so talking about the pros and cons of mobile, I've had a lot of guys that are inside gyms that close down or they do a renovation, all of a sudden they're kicked out of the building. And so there is some of those. I had someone who their HVA system went out, so they're in the middle of summer and they had no heat, and they couldn't do anything to control it because they don't own the building. And so there's some of those things that you look at. So that's why we aggressively grow as fast as we can, if possible. So then we can get into our own place where we control the environment and control all those type things. Because like if we're trying to be cash plus Medicare inside like a CrossFit gym, the Medicare population does not like going into a CrossFit gym. It intimidates them. Or if we
Right.
want to do like an educational workshop inside of a gym, they probably only let you do it during their off hours. Which if you have to do it during their off hours, there's probably not going to be a lot of people coming to the workshop. Or if you're inside of a CrossFit gym, the boutique gym, the powerlifting gym, the lifter gym, the sports gym, None of them refer to you because they're afraid that when they refer, they're going to start working out at that gym. And so that's why a lot of our guys, they start there because that's a good starting point. You can build some referral relationships. But then as soon as you get to your own, now all of a sudden, all those gyms that were never referring to you because they're afraid that they're going to lose their members to the gym you're in, now all of them refer.
Well,
And
I
so
never considered that.
yeah,
That
it happens a lot. Like, so I think people don't inherently understand that. And since it's becoming such a popular model, a lot of gyms already have a PT inside of them. So you also have to kind of have that competition a little bit there too. But there's a lot of niches out there, guys. Like you could literally do an entire practice on TMD. Like there's 5,000 dentists in your area, and every single one of them don't know that physical therapy can help with TMD. Their go-to solution is like, hey, stop clenching and grinding, do this mouth guard. If that doesn't work, stop chewing bubble gum. If that doesn't work, go to the oral surgeon. They're just not aware. I wasn't aware of it. My wife's an orthodontist. Like she didn't really even know physical therapy could help too much with it until I went to PT school. You like working with vertigo? Dental patients are amazing too. The moment they lean back, they're really hard to treat because they're a pain in the butt. And you're like, how do you even sleep at night? There's referrals everywhere. And so I think just figuring out what you like to treat, what makes a good day for you and why you want to do it, and then everything also kind of fall in place.
That's awesome, Joey. Thank you for that answer. One
Sure.
last question for you. Have you worked with many new grads starting their own business right out of school?
Yeah, we've worked with a couple of them. It's not as common because I think a lot of times when you're first coming out of PT school, you're just kind of even anxious on like, can I get the results for these patients? Much less the conviction of like, can I build a business? Can I charge premium cash prices? But I mean, I know one offhand that's up in Vegas. He started at 250 an hour right out the gate. And he now has 3 other PTs. He charges 350 an hour himself. He works with some of the pro teams up there, and he's done really, really well. But literally out the gate, he was working with like his own cash practice, 250 an hour. But I find that for the average physical therapist, I think that most people would actually benefit by going to work for someone for a year and just learning everything they possibly can from that business. Like you're essentially getting a paid internship to go work somewhere. And I think if you can kind of flip the frame on how you're doing it, not like, hey, I've got to go work for this person. It's, hey, I'm getting paid to go learn everything I possibly can without any of the risk. And when you think about it that way, it's a very different thing of going to learn from someone.
Mm. No, again, that's a great perspective. Thank you, Joey.
For sure.
Well, Joey, I want to be respectful of your time, man. I appreciate you coming on to educate these folks in this stuff. Where can people reach out to you if they want to see what you're up to or just have any follow-up questions or anything?
Yeah, I mean, you can pretty much, we've got socials on pretty much every platform for Dr. Joey Allbritton, or again, if you go to school.com, so skool.com/rehab CEOs, it usually asks if you're an owner or whatever, but you can literally just say you're a student and I'll accept you in, so you're fine. But yeah, any of those, or you go to rehabceos.com/media, that's like all of our profiles because we've got YouTube content. We're coming out with the podcast this month. We've got pretty much TikTok, you name it. I'm not doing dances. I know you want to see me dance, but I'm not dancing on TikTok or do anything like that. But so yeah, just reach out to me or you can friend request me on Facebook. I know old people still use Facebook. I know a lot of y'all in school don't. I was a second career student and everybody was on different things and I was still over here on Facebook. But I'm on Facebook, I'm on Instagram, I'm on YouTube, TikTok, you name it, pretty much outside of Snapchat. Do people use threads? I know that kind of was a thing and it kind of came and went, and I know Clubhouse kind of came and went too, but we were doing threads, but no one was on it, so we stopped doing that.
All right, man. Thank you so much. Always a pleasure, Betty. We'll talk again soon, I'm sure.
All right. Thanks, y'all. Y'all have a good one.
Thank you.
Thank you.